All right. Good morning, everybody. I want to welcome you to our 2023 HPV Vaccination Summit. We've been working really hard to bring this summit to you today, and we are excited to welcome all of you. My name is Megan Landry. I'm going to be MC today, so I'll keep us moving, and we have so many great experts today. Carrie, you can move on to the next slide. Today's summit is really brought to you by our Michigan HPV Cancer Prevention Alliance. This is a group of individuals across the state who are passionate about HPV vaccination and preventing HPV-related cancers. Our mission statement is to reduce HPV cancers and diseases in Michigan by increasing timely HPV vaccination through the promotion of awareness, education, and resources. So the Alliance are the ones who helped us secure speakers today, plan out questions to ask, and I do want to give a special shout out to my colleague, Carrie Murphy-O'Donnell, who really has been behind the scenes keeping everybody organized today to get us all here. Go to the next slide. Want to thank our sponsors. Thank you to Michigan State College of Human Medicine and to Blue Cross Blue Shield Network of Michigan for sponsoring today's summit and allowing us to put this on today. Next slide. Just a quick note about our CMEs. Feel free to take a look at this yourself and read it. But I think the most important thing to note is that there will be a survey sent out to all participants afterwards. And in order to receive your certificate, you do need to fill out that survey. So please make sure that you do that. Give you just a second to take a glance at the slide. Ooh. Thank you. Just one more second. All right, Carrie, you can move on. So let's talk about our agenda today. We have so many great speakers. We're going to hear from Dr. Marty Walsh from Blue Cross Blue Shield of Michigan. We have a survivor speaker, Jennifer Nagy. Our keynote presentation is from Dr. Diane Harper from Michigan Medicine. And then we have a panel of experts led by Dr. Sabrina Ford, and our panelists are Dr. Vivian Wu, Dr. Francis Darr, Jamie Vroman, and Consuelo Martinez. Those panelists will introduce themselves fully to really share what their role is in HPV vaccination. And then we'll do some next steps, wrap up, share some resources, and talk about the evaluation. Next slide. So let's get into it. We're really excited to welcome Dr. Marty Walsh from Blue Cross Blue Shield to share our opening remarks today. Dr. Walsh?
Hi, everyone. So my name is Marty Walsh. I'm a Senior Medical Director and Associate Chief Medical Officer at Blue Cross Blue Shield of Michigan. And I'm really thrilled to be here with you today to talk about HPV vaccinations and how we can work together to increase vaccination rates throughout the state. So I'm an OBGYN physician and I still do practice. And throughout my career have really worked to prevent HPV and also treat the diseases that are caused by HPV. So it's one of the reasons why I'm so excited to get to be here with you to talk about this. I think it's really important when we talk about HPV and we talk about the vaccination that we're talking about cancer prevention. And I think that's the way we need to frame this conversation. I was in my OBGYN residency when this tells you a little bit how old I am, when the HPV vaccination came out over 20 years ago. And I remember being so excited about having that vaccination. And I think now, 20 years in, we all thought at that time that we would be further along with our vaccination rates than we currently are. So it's really sessions like these where we're discussing the challenges and working to break down the barriers that will move us forward to increase vaccination rates and improve prevention of HPV disease and HPV-related cancers. So thanks so much for attending today. We have a great lineup of speakers and panelists, and I'm thrilled to listen and learn from all of you.
Thank you so much, Dr. Walsh, and thank you again to Blue Cross Blue Shield for sponsoring today. We're going to pop the slides back up. Just give us a second. It takes a second. Thank you. It is now my pleasure to introduce my friend and my colleague, Jennifer Nagy, who's going to share a really inspiring survivor story with us today. Jen, I will turn it over to you.
Good morning, everyone. If you don't mind, I'm going to read a little bit of my story to you. It's been a while since I've shared it personally and out in the world, and so I don't want to go all over the place, which I tend to do. So good morning. When I was asked to actually share my story, I was taken back a bit. It's been 15 years since I was diagnosed. I felt I'm not the right person. My story isn't recent or full of difficult decisions and details about a treatment plan. But then I thought about the opportunity and told myself my story is still important. And maybe I can convince just one person that it doesn't matter how your story starts, it's how you embrace the journey and focus on the outcomes so that you can benefit for the ending. So in 2008, I was just married. I was in my early 30s, and I hear the words, "You have cancer." That in itself is a shock, but working for the American Cancer Society, I had leaders and hospital partners. I had resources all around me um, to help me with that whole diagnosis. And it was easy for me to accept that at that time. I was able to embrace it and just understand what was my journey ahead. For that, I'm thankful. There were some difficult times, though, and difficult decisions that I had to make with my husband about fertility and treatment options. After weighing all the scenarios that were given to us and the feedback from family and friends, we chose to do a full hysterectomy, giving up the chance for us to give birth to our own child. It was not an easy decision, as we had hoped to start growing our family within the next year or so. I wanted children. I was a young girl who had cabbage dolls growing up and carried them everywhere. That's what I wanted, and that's what I knew. It was supposed to be the next chapter in my life, right? What I think is important for you to know is that I did get cervical cancer. However, I did do my cervical cancer screenings, and I'm a health advocate. I have worked for the American Cancer Society for over 25 years. So when this bomb was dropped on me, I didn't know what to say or do. I froze in panic. However, with the guidance of family and friends and ACS colleagues, I tackled what I believed to be the worst time of my life and came out ahead. Like I said, I knew about screening, but I didn't know about HPV. I didn't know there was a virus known to be the major cause of cervical cancer, a virus that had caused 6 other types of cancers. I didn't know there was a vaccine because I wasn't age eligible. I was already past the age to receive the vaccine. The HPV vaccine has been in use since 2006. That is the year I got married. The vaccine went through extensive safety testing before becoming available. More than 270 million doses of HPV vaccine have been given worldwide, and including 120 million doses in the US. But I didn't know about it, and I didn't know how safe it was. My parents didn't talk to me about HPV, and I certainly didn't hear about it from my doctors. But it's real. HPV is the reason for my diagnosis in 2008. 14 million people, including teens, become newly infected with the HPV virus in the US each year. It's very common. 80% of us have HPV, and we don't even know it. Statistics say that an estimated 35,000 men and women in the US will hear you have cancer caused by HPV virus in 2023. So fast forward to the world we live in now, we struggle with getting kids vaccinated and parents to understand the importance of this cancer prevention vaccination, let alone having our healthcare providers highly recommend it. I don't get it, and I simply don't understand. If we have a cancer prevention vaccine, why are we not at 100% or nearly 80% of our kids completely covered? Why is it still an issue? And why are we still talking about it? After all, it's been nearly 20 years. I often say if we had a breast cancer vaccine, we would do anything. We would line up our children and our girls to make sure that they got vaccinated. Over the years, I've had the time to appreciate my life in a different way and come to grips with what I've lost out on. But I have gained so much more by meeting women like me, learning from others, but also accepting what has been given to me and sharing how important it is to get our kids vaccinated. I have 10 nieces and nephews that you can bet have been vaccinated for HPV. I have a 23-year-old stepson that understands why he got the HPV vaccine at 13. I may not have had chemo or radiation, but I still had cancer. And now I take it upon myself to educate others, to learn and engage new groups to understand how safe the HPV vaccine is and the gift it is for our children today. The gift I wish I would have received between the ages of 9 and 15. But I also know that I'm extremely passionate about how far we have come in cancer prevention and screening. My hope today is that you will take this as a message. My hope today is that you will not take this message for granted, and you will empower your staff, your patients, your parents, and the community to learn more about HPV vaccination and to engage young kids into getting vaccinated early. I live in a county that is currently at a completion rate of 45% for girls and 43.5% for boys completely vaccinated. This is not a wonderful statistic. This is not something I'm proud of, especially since we've had the vaccine for 20 years. We're not even halfway there. We have not even gotten close to the national goal of 80% by 2026. I also work where there are counties that are much worse off. People I meet that don't even want to talk about it or make it a priority. So I promised myself I would make this chapter in my life count and to continue to share the importance of this gift we have, a cancer prevention vaccine. We have a gift in front of us of saving lives as vaccination, but it must start with you, and it must start today. We cannot wait anymore. We cannot keep talking. We need action, and we need to elevate this as a priority. My hope is that with these types of engagements and webinars that are offered, we can keep these conversations at the forefront of our medical experts and the community we serve. I believe we see an end to cervical cancer because we know much more and we are much more educated and we know how to prevent it. Just yesterday, I saw a post that I was trying to figure out how to wrap up today's call. And the post clearly talked to me, and it says, cancer is just a chapter in my life, not the whole story. And so I thank you for letting me share my story, knowing that I didn't know much about HPV, but I had the journey to be able to say, we can do a lot and we can make a difference if we all work together. Thank you.
Thank you. You got me a little emotional, Jen. Thank you for sharing your story. It's so powerful to hear from survivors, and you can hear the passion in Jen, and hopefully inspires everybody on the call today to move to action and to inspire the people around you to move to action. I did notice a couple people had put their hands up. If you wouldn't mind putting your question in the Q&A, we're not going to do verbal questions just because we want to make sure we keep on time. So any question you have can go in the Q&A box. All right, thank you. Carrie, if you want to move to the next slide. So we are thrilled to have Dr. Diane Harper with us today to deliver a keynote speech. Dr. Harper is an internationally recognized clinical research expert in HPV-associated diseases, their prevention, early detection, and treatment for the prevention of cancer. She's been a consultant for the World Health Organization and the Pan American Health Organization to advise on global guidelines and to set up screening and prevention operations in low and middle income countries to prevent cervical cancer. Dr. Harper has a strong interest in public health, epidemiology, and health behaviors, all fields in which she is widely published. She has over 300 publications and tens of thousands of citations, and has contributed to multiple textbooks and has participated in the US and global cervical cancer screening guidelines recommendation publications. She has been a member of the United States Preventive Service Task Force. Dr. Harper joined the instructional track faculty in the Department of Family Medicine at the University of Michigan Medical School in early 2018. Thank you, Dr. Harper. I will turn it over to you.
Awesome. Thank you very much. I'm going to start by sharing my slides. Is that working? We can see the right stuff?
Yes.
Great. Okay. So I do appreciate Jen's story, and I think it's really important to put a personal touch to this because I'm going to provide you with data, which can sometimes feel pretty cold and not without a personality. So I want you to keep her story in mind as I go through and provide the evidence behind which we have for understanding how important HPV vaccinations could be. In 2004 was the very first publication of large randomized controlled trials at the population level to show efficacy, immunogenicity, and safety of the first vaccine ever. So really, we are living history right now. This has really been something that's happened. Over the next, let me see how to do this. Over the next 20 years, we've seen changes. As Jen said, in 2006, the first HPV vaccine was approved for public use in the US by the FDA. And in 2017, 10 years later, a colleague and I published a review of all of the studies that had to do with HPV vaccination over that 10-year period of time. I encourage you to read this because it's a great historical documentation of what we knew at the time and evidence we had to make decisions about public recommendations for vaccination. But it's been 5 years since we published this, and time has gone on and studies have gone on. So what I hope to do today is review with you the next 5 years, what we have done since this publication in 2017. The key points that you need to listen for are efficacy, and efficacy means, does it actually work to prevent disease? Does it prevent infection? Does it prevent actual histologic disease? Immunogenicity means the antibody titers that are generated by the vaccine, and how good are those titers, how long do they last? And then safety. I'm not going to spend a lot of time on safety simply because, as Jen said, this has been given in millions and millions of doses, and while there have been some adverse events reported, we know that nothing in medicine is 100% safe. And so that just comes with the territory. We have given it this time now so that we understand when booster vaccines might be needed after that initial early childhood vaccination. We know that both money and politics have pushed us to evaluate a single dose vaccination for population protection. And we know that industry has pushed to move the approved age up to 45 years. So we also know that the patent protection on both Cervarix and the Gardasil products will expire in 2028, which will allow an opening for many more companies to develop HPV vaccines and provide this at less cost in the future to populations. This is the current vaccine uptake in the world. On the upside, many have been vaccinated against HPV, but as Jen said on the to-do list, many are still not vaccinated across the world. Some are not vaccinated due to choice, some due to cost, and some to availability. I want to say that HPV vaccines are a finite resource. We don't have infinite doses of them. And so we have to think about what doses do we have and how do we best use those doses to get efficacy against cervical cancer and other HPV-associated cancers. But clearly, the current uptake of vaccination is insufficient to prevent cervical cancer, any kind of large swath. So I will present now in very discrete categories what we've learned over the past 5 years. What do we know about efficacy of the HPV vaccines when measured by the prevention of type-specific infections and disease? And I'm going to start with the most important endpoint we all care about, which is cervical cancer, invasive cervical cancer. We are incredibly grateful to the Nordic countries because they have population databases where they actually track both vaccination and screening events as well as cervical cancer prevention. And what we see in the very first country I'm presenting is Denmark. They followed their young vaccinees from the very start of the phase 3 trials. And they have experience with all 3 commercial products, the 2-valent, the 4-valent, and the 9-valent. This particular slide shows that regardless of which vaccine, as long as there was at least 1 dose, and if the vaccine is received in girls younger than 17 years of age, there is a highly significant 86% reduction in invasive cervical cancer. You can see that in the graph at the upper right-hand corner called graph A, age at vaccination under 16 years of age. And you can see the cumulative incidence of invasive cervical cancer is very, very low, 86% reduction in these women who have been followed for at least 14 years. If the vaccine is given before 20 years of age, in other words, that B graph that you see on the picture, we see that there's a 68% reduction in invasive cancers after 14 years. But if the vaccine was given to women greater than 20, there's no difference in population-based cervical cancer control. Sweden's population reports a similar high efficacy. Again, that little green dot shows those girls who were vaccinated before 17 years of age, compared to the orange, which is unvaccinated. And what this shows is that there's an 88% reduction in cervical cancer when HPV vaccination occurs early. So we know this is significant. We know that this is predominantly because of 1618 prevention, and we know that this works. So I think that we owe great gratitude to our Nordic colleagues for being able to provide us this long-term population-based data. In Finland, they went one step further, and they said, will a 3-dose trial of vaccines prevent all HPV related cancers? And what they showed as the first publication to do so is that in those people who were vaccinated, that there were 0 cases of HPV associated cancers for cervix, vagina, vulvar, and tongue cancers. This is very powerful information. The remaining studies that I'm going to show you talk about surrogate endpoints. So we're going to move backwards in levels of importance. The first step is CIN3. That is the cervical cancer precursor that we detect in primary care clinics and that we treat in primary care clinics so that women don't have to go see GYN oncologists. This particular trial was done by the Costa Rica vaccine trial. It's a group out of NCI that has been using the 2-valent HPV vaccine in Costa Rica and has been following people. At this point, this is an 11-year follow-up, and it's looking at CIN3 disease protection over time. And what we see in this gold box is that as the years pile up in vaccination, from vaccination, what we see is vaccine efficacy continues to be higher and higher. So those people vaccinated at a very young age continue to be protected longer and longer that as time passes from vaccination. When Finland restricted their follow-up analysis to those who were vaccinated with the 2-valent vaccine given in 3 doses to 16 and 17-year-olds and age-aligned them with a population control without any vaccination, there were already 3 women whose HPV 16 was detected at baseline, and those women developed a CIN3 lesion. This reinforces the need to vaccinate prior to HPV infection. These long-term follow-up data show continued protection irrespective of HPV type. We now move to Scotland. And Scotland followed up after a 3-dose campaign and showed that there was very much a dramatic decrease in our CIN2, CIN3 plus lesions if the age of vaccination was young. That is what the data clearly show, and that we're able to prevent fewer cases the older we vaccinate. That is simply because once a woman is infected, the vaccine does not take away her current infection. This black dotted line is the reference of a 1.0 risk for those without vaccination and screening that started at 24 and a half years of age. This is the UK data. This is follow-up for 10 plus years after having vaccinated with the 2-valent vaccine. And again, what we see is both CIN3 and cervical cancer has a much lower incidence rate at the earlier the person is vaccinated. So certainly if you're vaccinated at 16 and 18, there's a reduction. But if you're vaccinated at 14 to 16, there's an even greater reduction. And again, at 12 to 13, the reduction is the best. China vaccinated their women at an older age, 20 to 45 years of age. And when you censored out women with baseline infections, the HPV vaccine continues to show high disease efficacy for their 6.5 years of follow-up. What we see on the top is against cervical disease, and we see that efficacy is high, ranging from 90 to 100%. And what we see on the bottom half of the slide is persistent infection. So this is infection that hasn't yet gone into disease, but infection that is detected at consecutive testings. These are 6 or 12 months apart. And we see that efficacy is ranging somewhere between 70 and 80%. Following that same Chinese cohort for 8 years, the disease protection shows that it comes from vaccine-relevant HPV type protection. What we see is that they don't have enough data to be able to provide some nice graphs that show you this, but clearly what they see is that if you are vaccinated, you have a much lower chance of having CIN3 detection. Now we move to the 9-valent HPV vaccine. This has been around not nearly as long, and we don't have nearly as much follow-up, and the trials have not been as large for the 9-valent as the 4-valent. And what we see from the 9-valent vaccine that's given in 3 doses after 4 years of follow-up shows the same message that we've been seeing earlier. The risk reduction related to 16 and 18 stays very high as long as you did not have an infection with 16 and 18 at the time of vaccination. What we see with the lower orange bars is that those are people who were had HPV infections that were 31, 33, 45, 52, or 58, and that they did not enjoy the same protection. So again, it's all about timing. It's all about having the vaccine before you're infected with the HPV types. Now we're going to move away from efficacy endpoints and look at another surrogate measure, which we call immunogenicity or antibody titers. This is the most immediate outcome that's measurable. It's used by regulatory bodies for surrogate evidence of future disease protection. The importance of immunogenicity is the titer level above what a natural HPV infection would give you. And how high these titers are gives us some idea about how protective the vaccine will be until a booster shot might be needed. The difference between vaccines is often seen only at the level of the antibody protection they offer. So in this study, Finland had 12 years of follow-up. They had 2 different vaccines they were using, a 2-valent and a 4-valent. The dark columns indicate disease efficacy. So in this case, it is persistent infection. The lighter columns, the light colors, indicate antibody titers, and we're calling that seropositivity. So that means, did you have a reaction at all? Did you make any antibodies regardless of their level? And what we see is that for the 2-valent vaccine, the efficacy against prevention of persistent infection was highly and statistically correlated to the antibody titers that are there. So we know that the antibody titers have a direct influence on the ability to prevent disease. Whereas with the 4-valent vaccine, that the association between seropositivity and actual protection against infection was not statistically significant. This is just a very graphic and easy way to see this. The red dots are above the blue dots. The red dots represent the 2-valent vaccine. The blue dots represent the 4-valent vaccine. And it's done in the very same antibody titers, the same system. You need different particular reagents and antigens to actually measure those titers. But what we see is of most concern is that 15% of the women who had the 4-valent HPV vaccine had no detectable HPV-18 antibody titers. And HPV-18 is incredibly important for adenocarcinoma protection. China is testing a 2-valent HPV vaccine with 3 doses, and they wanted to actually test again the age hypothesis. And they looked at, if you give it to young people, 9 to 17 years old, which are in the blue columns, versus giving it to older women, 18 to 25 years old, and follow them up for 8.5 years, what do you see as far as protection against the HPV type infection, and how good are the antibody titers that are made? And what you see is that the yellow or orange line shows the actual titers now, not whether or not they were seropositive, but actually measuring the titers of those who were seropositive. And what it shows is that in the older age groups, we have lower titers that are produced by vaccination than we do in the younger titers. So that's from China. Now we're going to move to the UK. And again, they are looking 7 years post-vaccination in a head-to-head trial using 3 doses of vaccine, and they're looking at the 2-valent versus the 4-valent. Now, as I do these comparisons, I don't really care which vaccine it is. What I care about is the amount of protection that we're getting. And what do we see with the vaccines and the products that are the adjuvant within the product itself? What we see is that the 2-valent vaccine has a greater type-specific seropositivity over 7 years and continues to have higher HPV type-specific titers. What you see in the right-hand side is that the blue line is above the red line or the orange line. And what that says is that you generate higher titers with the 2-valent vaccine than the 4-valent. The 9-valent vaccine, excuse me, the 9-valent vaccine was developed to address the weaknesses of the 4-valent vaccine. After 5 years, the type-specific HPV seropositivity remains above 75% for each of the 7 oncogenic types seen here in the gray line. The drop in titers in the orange bars at 5 years from the peak titers in blue is what we expect to see, and it's occurring proportionately for all 7 types. So we expect the peak titer to happen at 7 months post-vaccination, and then that titer to drop over time. And this is what we've seen at 5 years. This study confirms that vaccinating younger women provides greater antibody titers. This compares the titers generated against each of the 7 oncogenic HPV types for women vaccinated at 16 to 26 years versus those 27 to 45 years. Certainly, the titers are lower at peak measurement if you're vaccinated as an older person. The inference is that the duration of protection you will have if you are vaccinated as an older person will be shorter in time than if you were vaccinated as a younger person, but you will still have protection. So now we move to the fact that HPV vaccines are a finite resource, and having 3 doses is really hard to do. And so what do we get if we just give 1 dose of vaccine? How will that do for efficacy and immunogenicity? And so what we see is that there is a significant administrative burden to deliver the 3 doses compared to the single jab. With high type-specific antibody titers provided by the vaccine, the question becomes whether 1 dose of the vaccine will provide long-term protection, at least until the time of screening, to prevent cervical cancers. Because no trials were designed from the very beginning to look at a single dose, all of the studies we have are observational studies where only a single dose was received and the woman returned for follow-up. The only disease endpoint we have at this time for a single dose vaccine is the prevention of incident and persistent infections. The Costa Rica vaccine trial run by the NCI using the 2-valent HPV vaccine showed that after 7 years of follow-up, the women in the trial who had only received 1 dose had the same protection as those who had 3 doses that is type specific. So what we see in the light blue column that's high for all of them are the types that are not supposed to be prevented by the vaccine, and they weren't. They continued to happen, but they happened uniformly across all doses of vaccination. And what we see is that the prevention, the very small stubby columns in the darker blue, the orange, the green, and the yellow, are occurring only in those that are vaccinated. So it shows that 1 dose provides the same efficacy using incident infection as the outcome as an endpoint. In the same CVT cohort, now 11 years, remember the one we just looked at was 7, this is 11 years of follow-up. This is this is protection against incident infection, so new infection that happens. And what we see with 1 dose in that far right-hand column is that we have very high efficacy, and it's the same as what we would see in a 3-dose delivery system. So 1 dose appears to be just as good as 3 doses in providing efficacy. Again, now we look at persistent infection as the outcome instead of incident infection. And again, we see that across all 3 doses, 2 doses, 1 dose, we have the exact same vaccine efficacy. So this really has very strong evidence that 1 dose is as good as 3 doses. While the time frame for a follow-up is only 18 months in this cohort, 18 months is pretty short. This is a study done in Kenya called the Kenshi study, and it shows that 1 dose of the 9-valent HPV vaccine provides the same efficacy against persistent HPV-16 HPV infections as does 1 dose of the 2-valent vaccine. So I think this is also very encouraging to see that 1 dose of the 9-valent gives us the same protection as 1 dose of the 2-valent. Now we're going to switch and look at immunogenicity. So how good is this vaccine at developing antibody titers? How well does it stimulate the body to provide protection, and will that protection last for a longer time? What we see with the 2-valent HPV vaccine given in 1 dose is that it continues to provide more than 100 times the natural infection titer, giving really great reassurance that a single dose of the 2-valent will continue to provide protection over a long time. I specifically want to show you in these pictures that this black solid line is the natural infection titer for both 16 and 18. This is a log scale on the x-axis, and what you see is this purple line is the 1 dose. Which is the same over here. This is after 7 years. And you can see that this is 100 times, more than 100 times higher than the natural infection titer that you would get. When we now look at 11 years for this same thing, so we're following up even longer, we still have this black line, which is our natural infection titer. And we see 1 dose is again still 100 times higher than what you would see from natural infection. So this tells us that a 1 dose of the 2-valent HPV vaccine gives us significant long-term protection. This is a reproducibility study showing what the Costa Rica vaccine trial and the India trial have shown in their 1-dose observational trials. This is the 2-valent HPV vaccine, 1 dose, gives us slightly higher anti-HPV-16 titers at 24 months if they're vaccinated at a younger age. So again, age makes a difference. And we know for the 9-valent HPV 1 dose that its age-adjusted antibody titers are significantly higher, again, at 24 months for HPV-18 compared to the 4-valent. And this would make a difference in the adenocarcinoma protection. So something that's been bothering people is if we prevent HPV-16 and 18, will other types just come in and cause the same disease? And we won't really have done anything. We'll really just have cut something called type replacement or clinical unmasking. And so we are starting to see studies that answer this question. Again, the Costa Rica vaccine trial cohort, followed by NCI, now over 11 years, shows the following. It shows that 2-valent HPV vaccination resulted in 16.3 per 1,000 population reduction in our SIN3+. So that's this box. We also see that the reduction in SIN3+ caused by 31, 33, and 45 was another 1.6 per 1,000 people. So together, they give a vaccination. The vaccination caused a 17.9 per 1,000 reduction in SIN3+ incidence. Whereas we see that the type replacement did increase. There were more CIN3s by other HPV types, but that incidence only increased by 9.1%. So overall, you see that we are making headway in the reduction of SIN3+. This is a different way of looking at it. Clinical unmasking says that of those people who had CIN3 lesions, what were their types? And what you see is that the most common HPV types that took over were 52 and 58. And so it just says that there's importance of looking at multiple HPV types for the CIN3 that will happen. This is also a reminder that HPV vaccines are not going to prevent all cervical cancers. HPV vaccines are a bridge to screening, and in partnership with screening, HPV vaccines will help us reduce cervical cancer incidence. Finland actually looked at this with the 2-valent vaccine over 5 years of follow-up through 33 randomized communities. This was an amazing study done. 33 communities in Finland participated. Young girls 12 to 17 years of age were given 3 doses of the 2-valent vaccine. And what they saw was there was no HPV type replacement with the non-vaccine types seen at 5 years post 3-dose vaccination. There only was a 50% vaccine coverage by community, which is very real. That is what we're currently seeing in our populations. So now the other exciting part of this is that Merck and GSK have been making these vaccines under patent protection, but there are new places that are making HPV vaccines, and we're looking at where are they, what are they making, and what are the results of their trials. So in addition to Merck and GSK, there's a network of developing countries who manufacture vaccines. They provide 50% of the doses of vaccines procured by UNICEF globally. There are 15 manufacturers who have vaccine products that have been pre-qualified by the WHO, meaning that when their phase 3 trials show the intended outcome, that there is protection against incident and persistent infection and their antibody titers are sufficient, the WHO accepts that vaccine and allows that to be purchased for HPV vaccination worldwide. There are 4 HPV vaccine products currently in phase 3 trials. Specifically, so look at this on the right-hand side of this slide. What you see at the top is Merck, who has the 4-valent and the 9-valent. You see GSK has a 2-valent. Then you see the 3 companies, Innovax, Walvax, and Serum Institute of India, who already have phase 3 trials looking at HPV vaccines in China and India. There is another phase 3 study going on in China that's a 4-valent, that's a 3-dose vaccine. This we very much hope will provide us with many more vaccines, so the vaccines themselves won't be such a precious commodity. This provides a closer look at the companies that are in China who are actively developing another 9-valent HPV vaccine. 6 of these are already in phase 3 trials. So you can see these that are in the orange has late stage 3 trials of these vaccine makings. So this looks really hopeful for the future, not only for price reduction, but for ability to get vaccine to people. Unfortunately, only Innovax from China has actually published their results in an open access journal. So they're the only companies whose data we're actually seeing them worldwide. They do have 5 years of follow-up at 66 months. They used an E. coli process instead of a yeast process to make their vaccines. They did their studies with a hepatitis E vaccine control, and their outcome is prevention of any high-grade genital disease, SIN2, VIN2, or VAIN2. And what we see is that their vaccine efficacy was 100%. So they vaccinated 18 to 26-year-olds and then 27 to 45. So they actually started with a fairly old group of women that are 18 years of age in vaccination age years. It's important to know that the innovation in HPV vaccines comes from including all 14 high-risk HPV types, whether that's through an L1 or an L2 protein antigen. In these studies, we see specifically that the group in Germany over here is working on an L2, which will prevent against all 14 types. And we're very interested to see that there are others that are working on increased VLP proteins that include all 14 HPV types. That is when HPV vaccination may be able to provide us protection against cervical cancer. So there are other populations. I've talked mostly about cervical cancer, and there are other populations and there are other diseases, and we need to take a quick look at that. We know that men shows that the reduction in incidence of external genital lesions and anal lesions that are associated with 6 and 11, which are not cancer causing, as well as 16 and 18, is significantly higher if the age of vaccination is younger. So the younger age of vaccination is extremely important in young boys. That makes all the difference in the world as to whether or not they're protected against lesions. This is a particular study done in the most high-risk immunocompromised cohorts of men. It was looking at the 4-valent vaccine in HIV-positive men who were older than 27 years of age. And what we saw was that it was not effective against infection, certainly not against incident infection, and maybe there was some protection against persistent oral infections, but that it has a huge confidence interval and really would need to be looked at further. But the evidence of this is reinforcing to say it has to be in young ages and it has to be before HPV exposure. And finally, one of that's very exciting is, can maternal vaccination provide infant protection, especially for respiratory laryngeal papillomatosis? This is a small study that was done, and there seems to be maternal transfer of antibodies. What we see is that in women, 22 months from dose 1 of maternal vaccination to birth, there were 12 mother-infant pairs that received the 4-valent, 9 mother-infant pairs that received the 9-valent, and both of them had seropositive infants. And what we see is that the titers of the mother and the infant were nearly identical for the different HPV types and for the specific vaccines that were given. So this is very promising to think that we might be able to get some early protection in infants until they're actually vaccinated themselves to go forward. And in closing, I'd like to thank you again for the invitation to present this. Cervical cancer is preventable. Elimination is within reach. We need all of us together working towards vaccination, screening, and treatment to prevent this disease. I am delighted that the American Cancer Society has put this summit together and that so many of us are interested in amplifying our efforts through this work. So with that, I'm going to stop sharing and turn it back to Megan.
Thank you so much, Dr. Harper, for providing your expertise. There are a few questions coming in for you in the Q&A box. So let's just take like a few minutes, maybe 2 to 3 minutes to try to answer those and before we move to the panel, because I don't know how long you can stay on, Dr. Harper. Okay. So there's one that asks, do you vaccinate patients diagnosed with cervical cancer to prevent their future development of other high-risk HPV types?
That's a really good question. And what it does is shift the discussion from a population-based control of cervical cancer to a personal one-on-one treatment regimen for an individual. So there are people who say that, and we do know that if you don't have another HPV type, that you could consider vaccination. Remember that the 9-valent still only gives you 7 types. It doesn't give you all 14 types. It could give you protection against those types coming out. I will also say that there are others who feel strongly on the population side. I'm a physician and I see patients, so I will counsel patients to do that. But you need to understand that on the population side, there's significant reluctance to allowing us as physicians to use this limited resource for people who already have had infections, as opposed to getting these vaccines to people who've never had infections. But there is a tension in there, and as a clinician, I will provide that, I will counsel that, but knowing that we are using resources when we do that.
Okay. Second question, it's long, so give me a second to get through it. Given the length of time since development of preventative vaccination and longitudinal studies measuring efficacy of dosage and timing, is there work for development of treatment procedures to clear HPV before it progresses into cancer if individual screens positively during the screening?
Yes. Yes. Thank you, whoever asked that. We are currently doing a trial right now that is enrolling women who have CIN2-3 disease, because we do have a drug in a phase 1 trial that showed 70% clearance of the disease as well as clearing the HPV. So to everyone who is listening, if you know of or have patients with CIN2-3 disease who have not undergone a LEAP, please put them in touch with us because we are actively enrolling women. This will be the phase 2B trial that gets presented to the FDA. And so we are literally within countdown years to having something that will treat people who have HPV disease, not only to clear the virus, which LEAPs cannot do. Surgical procedures cannot do that, but also to then treat the abnormal cells that are there. So that is one of my areas of continued research. And so thank you for whoever asked that, because I think that's an incredible part of the cervical cancer control continuum.
Perfect. Thank you so much. So if you're able to stay on and you see questions pop up in the Q&A, which is at the bottom of your screen, Dr. Harper, feel free to type a response in, and Sabrina can also help call you out if we need to pull you in for some of the questions. But with that said, could we
actually, Megan, I have a question for Dr.
Sure.
Harper. So, you know, I'm not a doctor, but I've wondered about, you know, the 9-valent, which was expanded to address, as you said, some weaknesses and diversity and reach. And I've wondered, are there any studies that have looked at racial and ethnic differences in terms of types or efficacy? Thank you.
Sabrina, that's a perfect question. And indeed there are. And indeed, there are inequities. And indeed, what we see is that our African-American women have more of the HPV 50s, so the 51, 52, 56, 58, than the 16, 18s. We see that continent-wide as well. When we look at what HPV types are prevalent across the world, we see that Africa has a different distribution of HPV types than the rest of the world. Asia has its own distribution of HPV types, which means that while 16 and 18 overall really will make a big difference, it is to some degree discriminatory against other people who may not have those same types of infection. And so I think that's part of the reason why I'm incredibly excited about the pan-HPV vaccine development that's happening in Germany, where all 14 types will be developed, because right now nobody is planning on doing anything other than the 9-valent. They're not expanding to a 15-valent or some other. And so, which is also the reason why these therapeutic treatments that I'm working on are incredibly important, although we'd much rather have prevention at the early end than treatment at the late end. But I think that's really important. I have mentioned that to the American Cancer Society in asking for funding for some of my studies as well. It's an important point to note, and certainly in this day and age where we're seeing that there are significant health disparities in women's health by race, we need to address that. We need to face it.
Perfect. Thank you. That was a perfect question to end on. Thank you so much. Carrie, if we want to pop the slides back up so we can head into our panel discussion. Perfect. So Dr. Ford, I want to thank you for coming on to help moderate our panel discussion. Dr. Sabrina Ford is an associate professor in the Department of OBGYN and Reproductive Biology at Michigan State University College of Human Medicine. Dr. Ford teaches courses in the innovative shared discovery curriculum, specializing in the social context of clinical decision-making and patient vulnerabilities in health systems. She's a mentor and an advisor for medical students, particularly in women's health disparities. Dr. Ford's research focus includes HPV prevention and vaccination, cervical cancer screening and treatment, women's health risk behavior, health disparities and equity for vulnerable populations, and most recently working with Henry Ford Health. Dr. Ford also serves as a co-chair for the Michigan Cancer Consortium and is an active member of the Michigan HPV Cancer Prevention Alliance. Thank you, Dr. Ford. Dr. Ford, you're on mute.
All right, so that's typical of how I do things, but not really. I'm just really excited that today we have these experts, and thank you, Dr. Harper, for a very in-depth and enlightening presentation to get us all on the track for thinking about, you know, future of the HPV vaccine, and also what I tend to think of maybe not eradication, but maybe a little bit closer to where we can sort of think of those, you know, as a passing something. That's my kind of thinking for the future. Anyway, we have a panel on expertise today that's going to enlighten us on a very important and timely information. And now that the pandemic has somewhat subsided and we're back out and we can start communicating with each other more fully, we've got this illustrious panel, and I do mean illustrious, to kind of update us to get back out there and start thinking about the vaccine much more seriously, and maybe even doing some catch up. So what I would like to do is have the panelists introduce themselves, and I can, Megan, if you would help me to call on the panelists, and then they can introduce themselves, your affiliation, your credentials, and then also how you interface with HPV vaccine and whatever cancer disease state. Thank you.
Sure. Carrie, do you want to throw the slide up with their photos and we can go in order that way? Sorry.
Yep, give me one
Okay.
second. We're having a little
Behind the
trouble with the
scenes.
pinning.
Clicking. Thank you. All right, so we can start with Consuelo Martinez, if you could introduce yourself.
Hi, good morning. I'm Consuelo Martinez. I am a family nurse practitioner. My current role is manager of the Advanced Practice Providers with Henry Ford Health School-Based and Community Health Program. I've worked in school-based health for over 10 years, providing primary care services to youth and adolescents with a major focus on health promotion and disease prevention. Being in the school-based health clinic, it provides a great opportunity to meet youth and adolescents where they are, and it provides optimal opportunity to have the needed vaccine conversations with parents and patients, and sometimes repeated conversations to dispel myths and answer questions about vaccine. In addition, it's a great forum to have discussion about the importance of receiving vaccines that's recommended in general, all vaccines, and not only those that are required for school entry. So thank you for the opportunity to participate. I'm excited to be here to share my experiences and approach to help families increase their likelihood of vaccine acceptance.
Okay, thank you, Consuelo, and I'm now back so that I can see the panelists. So Dr. Jamie Froman, would you introduce yourself?
Yes, thank you. So once again, good morning to everyone out there. Thank you again for joining us today about this very important topic. I am the clinical pharmacy specialist for the western half of the state of Michigan for Meyer Pharmacy. My passion for the last 15 years has always been in the vaccination space. I'm privileged at Meyer to write our protocols and our CPAs, as well as training our pharmacists and technicians to not only administer vaccines, but to also identify patients as they're coming into our pharmacy. You know, we see some of my stores, you know, range from 600 to 1,000 patients a day that we see coming in every pharmacy. So we have a lot of patients that we could identify in need of vaccinations, obviously including the HPV vaccine. And, you know, not just, again, administering those vaccines, but as Jen, our survivor, stated, and I was so glad that she used this term, but making that strong recommendation to receive vaccination. So again, in retail and community pharmacy, we just have an immense opportunity to really move that needle and improve those vaccination rates across our communities, across the state, and impact a lot of lives. So thank you for having me today, and excited to hear where the rest of the journey takes us.
Thank you so much, Dr. Froman. Dr. Dar, would you introduce yourself?
Yes, good morning. I'm Dr. Francis Dar. I'm a general pediatrician in Marquette, Michigan, up in the UP, and also the chair of the Department of Pediatrics for Upper Peninsula Health Systems in Marquette. I've been doing general pediatrics for a long time. I finished residency in 2002, so before we had HPV vaccines, actually, and have been, as a pediatrician, of course, passionate about preventive care. I think that pediatrics is the realm of pediatrics is certainly preventive care. As a little bit of background, my mother had polio at the age of 16, and contracted it a year before widespread vaccination was available in the United States. And it affected her whole life, and I think was a major contributor to her death a few years ago. And that really is part of why I went into medicine, certainly part of why I went into pediatrics, and definitely part of why I'm so passionate about finding ways to be more effective at advocating for vaccinations. My practice has had a lot of success in getting higher rates of vaccination, and I'm anxious to share some of the strategies that we've utilized to get to that point. And so I just am really very, very passionate about this subject, and certainly think that we should be doing better as a healthcare community at getting these tremendously important vaccines into the arms of our young people.
Thank you so much. And Dr. Wu.
Good morning, everyone. Again, also a privilege for me to join this panel to discuss this area of interest of mine that's really been a passion. I think I really did appreciate Jen's 30,000-foot view of her experience, and really grateful to her to share it. I also got a little emotional. So, after, of course, the patient's experience, the family's experience, I think I'm a head and neck surgical oncologist. And so I see a lot of the head and neck cancers I see head and neck cancers that are out there. Majority of my patients actually are men that have this disease. And so I'm going to offer that sort of perspective. But again, after a patient and family's experience, I think that as a surgical oncologist, I really have the privilege of walking these patients through this experience, which is, at times very difficult, and also leads me to say, hey, if we have something to prevent this experience, why don't we? And so it really has been a passion of mine to share what I'm seeing in clinic, and a way to say, hey, if we can prevent this, please, let's do that.
Thank you so much.
Yeah.
I'm sorry. Were you finished?
No. I wrote to say also I'm out of Henry Ford Health System. So, and I don't have my background screen.
Yeah. So Dr. Wu and I actually are working on looking at providers and their kind of attitudes and intervention in delivering the HPV vaccine. And it's been a real interesting journey, and we're just kind of writing up those results now. So thank you to the panel. And I'm not sure if Dr. Harper, I do see her, is still here. And so we're going to start with some sort of basic questions. And before I do that, actually, I'm going to ask a few questions, and then we'll turn to the audience and see what questions they have for us. And depending on how many questions we have coming in, because we do have I've been told that there were 300 persons registered. So this is a nice group, and there probably are varying levels of knowledge and expertise. So I'm just going to start out and see if one of you would want to describe, and maybe even in layman's terms, what is HPV? And maybe Dr. Harper, before you leave us, if you could describe the virus.
Sure. The technical thing is that it's an 8,000 base pair double helix DNA virus. It is unlikely to mutate as a virus because it would take 10,000 years for it to mutate. So it's not mutation of the virus as much as it changes in virus types that we become worried about. The virus is circular, and when it infects the basal cell of the epithelium, it often stays circular. And when it stays circular, it's really not a problem. It's just like any other infection. It's just like, you've got a pimple on your face. It's just not really something that's an issue. But when that circle breaks and that HPV DNA inserts itself into your DNA and becomes part of you, that is when the cancer process starts. That's when the earlier CIN3 lesions become detectable. And so it's a very small virus. It can only enter basal cells, there are two very specific receptors that allow it to be sucked into your cells. And if those two receptors are not working, then you don't get infected. And so I think it's important for people to understand that, because I've heard some really bizarre things about, HPV can infect your heart muscle. Well, yeah, no, it really can't. It has to infect that very specific skin cells that have very specific receptors saying, come in this door.
Thank you very much. So, and for any of you, how common is HPV? And I'm sure many of us have looked at the statistics, and you don't have to quote statistics, but you certainly can give us a view.
So HPV is astoundingly common. Every time you see someone with a wart, they have an HPV infection of some sort. And of course, the focus of HPV vaccination is against invasive disease. But I always introduce to my patients when I'm talking about what HPV is, exactly that. If you've ever had a wart, you've had HPV infection. And there are, and I am not a researcher, but there are 200-ish serotypes of HPV. But there are, as we've already talked a lot about today, some of those serotypes are much more likely to become invasive. And to make it simple for my patients, I would say, if they get on a mucous membrane, because that's kind of the common theme, whether it's your mouth or your vagina, or your cervix, or perianally, those are all mucous membrane-y kind of tissues. And so if they get on a mucous membrane, they can become more invasive and cause cancer. And that's, of course, what we want to prevent. And so that's kind of the simple patient-oriented spiel that I give to all sorts of kids and their parents.
Yeah, I think Jen had mentioned it in her intro that about 80% of us will get HPV. So it's quite a high number. And as Dr. Harper mentioned, it's great that if majority of us, that DNA stays circular, we don't have a problem. We just don't know who are the peoples whose DNA breaks and integrates. And that's really who we're targeting with this vaccine. I think also, just to mention the 2-valent, 4-valent, 9-valent. Within the 9-valent group, there's 2 benign subtypes that are covered, 6 and 11, and only 7 of them are for the malignant types. And so,
Okay.
Yeah, and with 14 million, new cases every year, that's a lot of opportunity that we have to impact many lives. As someone said, and I'm not sure exactly who said it, but not just the patient, but the entire family is affected by this.
Right. So, I'm not going to, I have some other questions here in terms of, how it's diagnosed, how it's treated. And I think that we could get into that, but we could get deep in the weeds. So I'm going to sort of get to the HPV vaccine. But I do want to say that HPV associated cancers are what we're trying to prevent. And I think it's in my mind, a no-brainer that the vaccine, as Dr. Harper has shared with us, has great efficacy and could really have a great impact on reducing HPV-associated cancers. So I do want to ask you, who should get the HPV vaccine? And Dr. Harper sort of showed us, how effective it can be in age groups, but who should get it?
I'll venture an answer here. All eligible children should be vaccinated for HPV. And that is the strategy that's going to be most effective at eliminating these cancers. We moved in our clinic from a strategy of routinely doing HPV vaccination and recommending HPV vaccination at 11 years. We have moved back to starting that recommendation as soon as those patients are 9 years old. And we've done that for a couple of reasons, and I think it's important to kind of talk about why we found that to be an effective strategy. We know that the immune response is stronger as you're younger. And there's not evidence really, I don't think, that it's stronger at 9 than at 11, but we know that it's stronger at 11 than it is at 16. And so one of the things that we observed in our practice was you'd start to introduce the topic at 11, and maybe families were a little bit hesitant, and they'd say, you know, I'll do it next year or the year after that. And so we have found that by just starting the conversation at 9 and saying this is what we recommend, that we get better uptake by age 11. We get a lot of people who do it at age 9, but not everybody. But a lot of those who say at 9, I want to talk to my husband about it. I want to think about this. I want to do a little bit of research, that by the time they're back at 10 and 11, they're ready to proceed. And so that strategy has been really an important way for us to increase our vaccine uptake. The other thing we talk a lot about, and we should talk a lot about cervical cancer, but head and neck cancers and HPV, I am not convinced by the data that I've looked at that HPV cannot be transmitted to the mouth much more casually than sexual contact. There's no evidence that I have seen that convinces me that kissing can't transmit HPV to the mouth, or that, and we just don't know, but if you have a wet surface where someone has, you know, where there is some HPV, because we know that warts can be transmitted that way sometimes. But if you get the right strain and you touch that wet surface and then you touch your mouth, can you not pick up HPV that way? And kids certainly have their hands in their mouths all the time, right? And so I worry about that kind of more casual transmission. So I think doing it younger also has the potential to, because it's only primary prevention, to prevent that infection in those 9 to 11-year-olds. And regardless, if we get better uptake with doing that recommendation, I think it's worthwhile and wise. And certainly the other piece of that I think helps with uptake is at 11, when you start to talk about HPV vaccination, I think a lot of parents are just starting to think about the possibility of sexuality as a concept for their kids. At 9, they're not even thinking about it. So somehow the barriers seem a little lower for acceptance at 9, because they're not thinking, oh, and I think that's a barrier that shouldn't exist. But certainly psychologically, I think for some parents at 11, just the thought that their child might be a sexual being on some level is as scary as anything they've ever thought of. And at 9, they're not even thinking about it. And so sometimes we get a little less opposition there.
Yeah. So does anyone else want to sort of visit that question in terms of, you know, who should get the vaccine? Or
Yeah.
Go ahead, Jane.
Yeah.
Jamie.
So in the pharmacy, you know, we do see a lot of adults, honestly, just because of the shared clinical decision making now that expanded the recommendations for the 27 to 45 group. We don't dabble too much in pediatric vaccines in the pharmacy, just because the pediatricians do an amazing job at that. It's a little more comfortable for the kids too, probably us as well, for the pediatricians to keep that. But we are starting to see a lot more adults come in and ask about, you know, specifically a lot more men, to your point, and the head and neck cancers, because of, you know, there's commercials out there now. So we are seeing more in that group, definitely in the last year, which is fabulous. To the point, this vaccine obviously is only prevention and moving forward. So if they are already infected, unfortunately, we are not doing anything for that piece, but hopefully the awareness spreads, and we can, you know, trickle down to some of these younger groups as well and increase vaccination there. But definitely starting to see more in that shared clinical decision-making group of the 27 to 45.
If I can just kind of echo a little bit, Dr. Dar, as far as introducing the conversation early on, I think doing that is great, as well as it also benefits for those parents who are concerned about their children getting so many vaccines. If we get the first dose in before age 15, the benefit of only needing 2 vaccines instead of 3, I think is something that's a selling point, I think, to families.
Yeah, the earlier the better. And I didn't know if Dr. Harbert, did you have a response to any of the I just am feeling so blessed that you're still here, a response to any of these thinking around age?
Well, I think that the WHO has made the recommendation that we go to one dose. The evidence is sufficient worldwide. In the United States, it hasn't been approved for one dose because literally it impacts Merck's income. And so there is little drive for Merck to get it approved as a one dose vaccine. But I think my question to Dr. Dar would be, if you were able to present to your patients, hey, we just need to give you one dose, as opposed to 3 doses over time to these young kiddos, we have the evidence to show that's protection. And whether they come back for dose 2 and 3, I don't particularly care. I care that we get that first dose into them at a young age. And so I wonder if it would, I don't think anybody studied this to look to say, I don't think we have any behavioral data to say that if you were to approach a patient with a 9-year-old and say, all we need to do is give them this one dose right now, and we don't have to worry about it, we don't have to talk about it, whether we wouldn't have a greater uptake. But I don't know, I'm not in your shoes and I don't see those patients. So I'd appreciate your thoughts.
I think
Well,
potentially, yes, we could see greater uptake. There is no question that talking about the 2-dose for patients under the age of 15 versus 3-dose over the age of 15, that is something that at that 13 to 14 year age group, for the people who have been hesitant but think they're going to get it eventually, we see a lot of those at 13 say, yep, it's time because I don't want to go through an extra shot. So yeah, I really think a 1-dose series is it's always more palatable to have less needles. And I think it's more palatable for kids, it's more palatable for families. So as far as, I mean, I don't know that it would be a tremendously big difference in the number of people who eventually get it, but it might help us to get it sooner. If you say, boy, it's just the 1 dose today, and then you never have to think about invasive HPV again, right? That is, yeah, I think that would be an effective strategy.
okay, so I wanted to so I just want to ask a question from the audience, so that has to do with age. And so the vaccine has been approved for women and men up to age 45. And so is this even with the history of HPV? We've talked a little bit about that, but is it still probably good recommendation, or when would you do that? I mean, Jamie, you had talked a little bit about how you're seeing older persons now. So any thoughts about that?
I love the fact that recommendation was expanded, just because, and this is something that I actually bring up with patients and pharmacists that I'm training when they ask. And some of these topics are obviously uncomfortable, and we get into those as Dr. Dar has already mentioned. It's hard to talk about someone's 12-year-old and, well, this is sexually prevented illness, and getting them younger obviously takes some of that out. But I had a conversation actually with my sister, who's a nurse. I love to tell my other pharmacist this. She didn't want to get her slightly older teenage daughter protected because she's a great girl, was actually my sister's quote. She is a great girl. But say she gets married, right? Wonderful, wonderful husband, but something tragically happens at age 27, 28, 29. And now we need protection because husband has passed away. There was a divorce. So this really allows us, to protect people who are at a different stage of life, who maybe have or could have an exposure. So I don't know if that, fully kind of answers some of those questions, but I think that it was an important step to expand that
Yeah.
age group. Just because we have unfortunate life happenings that happen later in life. And I didn't have the HPV vaccine available to me. I'm not going to state my age, but it was not around when I would have been eligible for it at a younger age, but I am eligible now. And I did get, I got it. I'm happily married, but you just don't know. And prevention is key here. So
Right.
I think that was a great expansion.
Yeah, I think, now that we know the efficacy and the safety, that is a really good expansion. So I'm going to go ahead, and we've got a number of questions coming in from the audience, and then, given time, I'll come back to some of those that we've thought about as a group. So now, Jamie, another one for you, and I'm sorry to put you on the spot, but so any thoughts on Meyer pulling MICR on all patients to promote vaccine conversation, or only generated when the patient comes in?
Oh, that is a heavily weighted but great question.
Oh, Michigan and their MICR.
So I love MICR.
I do too.
It's fabulous. I can say that, Meyer practices in 6 states, and it is leaps and bounds ahead in Michigan of what a lot of the other states are that I dabble in. So it's fabulous, great tool. I would love to be able to MICR every patient who comes into the pharmacy, 800. That it would get very difficult. Unfortunately, we are a business and we do have to get their prescriptions out. So that's primary function. However, we do have certain policies in place in our pharmacy. So and COVID still feels like a dirty word, but yeah, there were silver linings in our technology. And I'm sure this is not just Meyer, but advanced drastically. And what are we able to do online? What are we able to do to, to help our health systems out, right? So when patients schedule their vaccination appointments with us, we MICR obviously all of those, don't want to make sure that there's duplicate vaccinations given, want to make sure it's appropriate, things like that. So we MICR, of course, all vaccine patients coming through. We do have some policies in place to MICR, diabetic patients to look at pneumococcal vaccines and things like that. And anything that a patient is missing, we certainly do highlight and discuss that with the patient. Unfortunately, we are not there yet where we have the time and just the personnel resource to MICR all 800 patients coming through in a pharmacy. But that would be a dream.
Again. So Consuelo, if I could ask you the same about, you're with school-based, and I don't know if that's something, I hadn't even thought about HIPAA, but is that something you would ever do, is to see if children are vaccinated or that kind of thing?
Absolutely. Every patient that comes through our doors in the school-based health center, we are checking their MICR for every visit and addressing any missing vaccines, offering them the same day, and making appointments, if they can't have it done that day. So yes, absolutely, we do that.
So, and also for Consuelo, so is there opportunity, or what's the opportunity to vaccinate in schools? Do you get much pushback? Are you able to navigate that with parents, or how does that work?
Yes, both. I would say, as in any, I think clinic that you would go to, you get those that are that seeking that service, and then some that you have to, have conversation with to kind of answer questions and make them more comfortable with making the decision to vaccinate their children. But yeah, we have vaccines in all of our Henry Ford, all of our school-based Henry Ford clinics that have some nurse practitioner in it, as well as RNs. We do offer that. The schools we're in appreciate having that opportunity, because we help them meet their number numbers for the state with vaccinating students as well. So again, with any clinic environment, you have some that are reluctant, but the form that we're in, we're able to have those conversations, and the time that we have to actually spend with those patients and families is beneficial, so that we can have the opportunities to answer all of their questions.
Okay, so thank you. I mean, it's just so important to talk about strategies, and I know, HPV is important as as a virus and a disease state, but also, if we can prevent it, I think that's probably a key here with an extraordinary vaccine. So Dr. Wu, I have a question for you. So what trends are you seeing in head and neck cancers?
Yeah, so in head and neck cancer, and I know we focused quite a bit on cervical cancer this morning, and I think one of the reasons is that 91% of cervical cancers are due to HPV vaccine. For the head and neck, our area that is affected by HPV is the back of the tongue, or the base of the tongue, and the tonsils. About 70-ish% of our base of tongue tonsillar cancers are due to HPV. In 2010, actually, there was this flip. So there's several graphics out there of a pyramid or an iceberg and that type of thing. And in terms of the base of that pyramid or iceberg, it was cervical cancers, or actually genital warts, et cetera, et cetera. And then the next level was cervical cancers. And after that was oropharyngeal cancers, oropharyngeal being, or oropharynx being that base of tongue or tonsil region. In 2010, there really was a switch. And so, just sort of ballpark numbers right now is there are about 14,000 new cases of oropharyngeal cancers per year, and there's about 11,000 new cases of cervical cancer. So it's really, remarkable how, was that due to the vaccine? It's hard to say. It's possible, but I think it's remarkable how oropharyngeal cancer has really just taken off. I had mentioned earlier that I mostly see men, and this is true for oropharynx cancer in general. It's about anywhere from 4 to 6 times more men are affected by this or have this cancer as opposed to women. So yeah.
Yeah, that's a good statistic to know, because I didn't actually know that piece of it. I knew that head and neck cancers were surpassing cervical cancers, but I didn't know what the mechanism there. So that's really interesting to think about. And I, in my mind, and of course this is not scientific, is that there's been a cultural shift in generations too, in terms of contact, of where HPV virus might be found. So I have another one for you, and I'm sorry to just focus on one person, but they're coming in from the audience. Now, are there specific high risk? This is for you, Dr. Wu. Are there specific high-risk types of HPV, and maybe Dr. Harper, associated with head and neck cancers?
Yeah, I think Dr. Harper mentioned the 50s for cervical cancer in African Americans. I think, I'll be honest with you, I don't know if that we've parsed it out by ethnicity as much in our head and neck world. That being said, about 95% of our HPV diseases are from HPV 16.
For men?
For all comers.
Okay.
Yeah. And so this idea of clinical unmasking is something that I actually, Dr. Harper, thank you for educating me. It's a crazy, obviously it makes sense, but also something I haven't really thought about. So, we vaccinate HPV 16 and a bunch of the other ones pop up. It's certainly something that can happen. But as of right now, our numbers are that about 95% of the head and neck cancers are from HPV 16.
Okay, so I'm gonna sort of open it back up, even though people are very curious about this. So how are we engaging oral health providers in adolescent and adult populations? So I don't know if any of you, I have heard it at a previous summit, there was a dentist that actually had given a terrific presentation. So any thoughts around engaging oral health providers?
Yeah, I think it's certainly true that the most comprehensive oral exams are done by dentists. And so we often see in pediatrics, it's not oral cancer so much, but we often see mouth-related pathologies first coming to us because kids go to their dentist and then their dentist says, hey, you know, you need to go see your pediatrician because I see this in your mouth, or your tonsils are big, or, you know. And so that kind of very comprehensive look in the mouth that happens with dental hygienists and dentists, certainly my colleagues who are dentists are passionate about HPV vaccination and have been allies with us in trying to promote HPV vaccination because they see those cancers. So definitely they play, I think, a vital role in identifying oral pathologies, including head and neck cancers.
Terrific.
We've actually seen several referrals in to the pharmacy to get the HPV vaccine from dental offices. And that's been much more common in the last year, you know, with a nice thorough head and neck exams by the dentist. And then just, you know, hey, have you had this? Think about it, you know, go into your pharmacist and get this vaccine. So we've been hearing that a lot more lately.
Yeah, I mean, we need to partner with several dental groups, and we've actually given several symposiums to sort of like Oakland Dental, and I had just given a pretty large symposium for like 700 dental hygienists. It's like, it was a kind of amazing. They all joined in to hear about HPV. But, you know, I think somebody had mentioned about the exam, you know, you just want to, sometimes the focus is on the teeth, but those who are very, you know, very interested and thorough really just kind of look just beyond the teeth to evaluate that tonsil region. I want to mention, though, actually the most common symptom of patients coming in with head and neck cancer is not necessarily you can see the tonsil, but they come in with a neck mass. And frequently these patients have a painless neck mass that's been treated with antibiotics, 2 rounds, hasn't gone down at all. That in you know, a 40 to 60-year-old man is something that needs to be worked up from a head and neck cancer perspective. Absolutely. So that's some good information.
Yeah, you know, and to sort of, you know, we've got the audience now thinking about these kinds of things because, and that's what I was hoping for, is that we would think, yes, cervical cancer in women, but also, you know, men are being affected at an overwhelming rate as well. And so I'm just thinking about, this question comes to me a lot in terms of screening. So we know there's screening. And, you know, that's another tool we can use with the vaccine for cervical cancer, or, you know, even prevention early on with the PAP and the HPV test now. How about in head and neck? How, if anyway, can it be screened? And is there anything in the works?
So we currently don't have any good screens. I think several of the studies that are out there, Maura Gillison put out a couple of great papers kind of looking at efficacy actually of vaccinated patients. What they did use was a salivary, a spit test basically, to evaluate and look for, was a DNA or protein within the spit. That being said, I don't think it's the best test out there. We don't have a PAP in oropharyngeal cancer. It's kind of impossible for us to actually take a swab and swab every single surface of your tonsil. And in fact, the base of tongue is, I mean, this would require a trip to the OR, and the accuracy and efficacy of doing that is not there yet. So we don't have that. You know, embarrassing to say, I don't know if there's anything in the works, to be honest. I don't think there is. I don't know if Dr. Harper knows any different, but I don't think there is, aside from trying to evaluate spit tests, which would be amazing. I don't think we have anything out there.
I would like to bring up at this point that we've been talking about PAP tests, and I would like this audience to know that cytology is dead. We're really not doing PAP tests anymore. We are HPV tests, primary HPV tests. And we're doing that because HPV is what causes it. It causes 99.7% of all cervical cancers. It is the only preventive test that we have for any of the HPV-associated cancers. We don't have a screening test for anal cancer or vaginal cancer or vulvar cancer, or, as Dr. Wu said, head and neck cancer. We don't have something at a population level that makes sense. So I would also like to have the people who are in this webinar and in this program take back to everybody they know that PAP is dead, and it's HPV primary screening is the next screen for cervical cancer screening. The ACS came out with this as guidelines. The USPSTF has come out with its guidelines. And if you're going to be up to date in your cervical cancer screening, you should be doing primary HPV testing as your primary screen.
Yeah, that's interesting that you bring that up, Dr. Harper, because there are still some providers who are doing co-testing, meaning the PAP test and the HPV. And so, whether the memo is out there, and I think, part of the reason that the PAP test was not only risk is a slow growing cancer and a risk, but also, disturbing tissue or cells on the cervix versus HPV is a very accurate kind of test that is, I don't think it's less invasive, but what would you say to providers who are still providing a PAP? I mean, it may come that the payers actually will say, okay, we're not paying for that.
Yeah.
And then also doing co-testing.
The co-testing gives you a 60% greater number of women with false positives. So you are sending 60% more women for colposcopies than need to go. And that's a very uncomfortable thing. And it's not part of the ACA. So that's women's out-of-pocket costs, whereas screening is completely covered with no out-of-pocket costs.
Okay.
So I think that the message to give to people who are hanging on to co-testing is that you're hanging on to a dying test. Very soon the insurers will indeed say we're only paying for primary HPV testing for the average risk asymptomatic woman.
Okay, so anyone else want to comment on that? Because that is what I'm finding is very kind of confounding, and to talk to providers about it, they feel comfortable. And then also women ask for their PAP. And, when the recommendations changed from, every year to, depending on your risk level, to every 3 years, women were still asking for the PAP, even though HPV is much more accurate and comprehensive. So, I'm going to move on because there are.
I'm going to say, Sabrina,
Yes,
that what
please.
we need is another educational conference just like this that's focused on vaccination to focus on educating nurse practitioners and pharmacists and all of our physicians who provide primary care about how we need to be moving to primary HPV testing. And then we can get back to vaccination.
Yes, and then we can get back to vaccination. So I think, so any last comments on that? And then I have a lot of questions here. I'm glad people are excited about this. And we're covering some things that, we haven't really touched upon. I mean, it's been 3 years since we were all kind of locked down and we've been in our cubby holes studying and learning and whatnot, but we've not shared with each other. And so this is fantastic. Let's see. Now, someone, I hope I have this right, and Megan, you may have to step in and help me with this question. So, what about over 45? And
yeah, there's been a lot of questions in the Q&A about recommendations for over 45 and options for that demographic. And I know, Dr. Wu, I think you had put in the Q&A that you might be able to answer that.
Oh yeah, only because I thought I could type it, but it wants to answer live. I'm happy to to attempt this one, but maybe somebody else is more well versed in it. But first off, I think you heard FDA has only approved it through 45. And as Dr. Harper kind of mentioned, really, you got to get the virus, you got to get the vaccine before exposure. And I think at least the current data shows that after 45, it's more likely that you've been it's possible that you've been exposed. Have you been exposed to all 9 subtypes that are in that 9-valent group? I think that's the reason why it's not approved. But again, Dr. Harper or Jamie, if you want to comment, I'm happy to.
There is, I mean, literally.
Yeah, any of the panelists. Thank you.
Yeah.
Go ahead, Dr. Harper.
No, there literally is no evidence to show that vaccinating, nobody is doing studies greater than 45 to look. We are taking the theoretical understanding of the basic sciences of how HPV infects how people produce autoinfection when it's still in the circular form, they're continuing to reinfect themselves all the time, as a reason for using vaccine in people that may be older or may have other risks. I will say that because it's greater than 45, your insurance company won't cover it. Merck is currently charging about $230 per dose, and there'll be an administration fee on top of that from getting it. And so it becomes a very expensive, nearly $1,000 expense for you to get 3 doses as an adult. So it's something to think about. It's an option if you have discretionary income. Yeah, go for it.
Thank you. So in thinking about this diversity, as I brought up earlier, in terms of, who might be at greater risk, what about in the LGBTQAI community, and any thoughts around or data around risk levels or rates?
I can take an answer at that.
Okay.
The other panelists, please jump in. What I have learned is that most of the lesbians have had an experience with male sex partners at some point. And so therefore, even if they're exclusively with female sexual partners, they are at risk because this is a skin-to-skin transmitted disease. And so we think, as Dr. Dar was talking about, fingers in anus, fingers in vagina, fingers in mouth are potential. It has to be skin-to-skin. It's not something you're going to pick up on the toilet seat. Please don't be afraid of the toilets, people. Please use the toilets in the right way. But I think that it makes them certainly at risk. Are they at, and the other thing to know is that for a woman, her risk of getting HPV is not only her number of sexual contacts, but it's her partner's number of sexual contacts. And so wherever her partner's been and who her partner's been with is who is coming to that relationship and that possible exposure. So we definitely know that for men who have sex with men, that the incidence of HPV infections is very high. We know that it starts at a really early age, which is why it's so important for us to get boys vaccinated as early as possible. We talk about cervix, but we have cervical cancer screening for girls. We don't have that for boys. And girls are adventurous. Boys are even more adventurous sexually. And so they try lots of things. And so we need to really, that's kind of why it's like, hey, Dr. Dar, your 8-year-old boys, will you at least get 1 dose in them? It's like, we really are looking to try to do that because they're not sure what their gender is. They're not sure what their sexual preferences are at that point. And we know in that study I showed you of men who are over 27 who are MSM, who have had HIV infection, even if their HIV infection is very well controlled, but they still really don't get much protection from the vaccine. So all the more reason to say that while we're worried about this for young girls, we're really worried about it for our young boys.
That's excellent. Anyone else want to add to that? Dr. Harper, that was really enlightening. I'm really glad to that we're talking on this level. I mean, we are talking about the vaccine, and we kind of know that, or I've been thinking about the vaccine, but we know that that is an efficacious, safe, effective way to prevent. But the ins and outs of knowing how and why HPV is associated with cancers is so important. And I'm glad we're really talking at this level, because that is the message that we can also give to our patients in terms of cancer. And that's why, there has been more focus on cancer than the sexual nature of contracting HPV. So there have been a number of questions actually about HPV testing. I mean, we've talked about screening, but how about the recommendations of, we don't have an OB here, but the recommendations for, we talked about the HPV test, and we know that that's not necessarily, or it is not available for other, anal, genital cancers and head and neck. But what about recommendations for the HPV test for women?
I feel like I'm hogging the panel board.
No. Well,
So but I will say that this is where I'm spending my life right now.
okay.
The HPV test is for detecting HPV genotypes has a sensitivity of 96%. In other words, doing an HPV test on people without cytology will find current CIN3 disease, incident CIN3 disease. It is superb at finding what do you currently have with a single test. And we do that by HPV genotyping. We know that if you are HPV negative, you are good for 5 years, because if you would get an HPV infection, it will take at least that long for it to do anything to you, much less be an early precancer. So it's a very safe screening interval to go every 5 years with a negative HPV test. We are moving the NCI. I am one of the PIs on the trial for the NCI that's called the Last Mile Initiative. And this is to put self-sampling into women's hands. It is to allow women to self-sample, because you cannot get HPV to the cervix unless it goes through the vagina. It has to get there. That's the only way it gets there. It's not in a miraculous kind of infection that happens. And so by putting a swab in, just like women would use a tampon, but very thin, very easy to use, women can self-sample for HPV and have that sent in. If you are negative, you are good for 5 years. We are doing this trial with NCI because right now self-sampling is not FDA approved. And what we have to do is get the right device with the makers who do the HPV tests so that women can then use those, whether they want to do it in the clinic that day or whether they want to do it at home and mail it in, becomes a question of healthcare systems and logistics, not a question of accuracy of testing. So it really brings it to the patient and makes screening patient-centered, helps us understand that. It's also one of the ways that which PAP is dying, because we don't know we know that cytology is not that good. We know that cytology has a 50% sensitivity. It only detects half of the CIN3s that are already there. So yeah, so we're moving that direction. I think that you need to ask your doctors, what are my HPV results, and be much more interested in what those results are than what does my PAP say.
Many of the recommendations you can also find on ACS website, you can find on CDC website, and also NCI's website, or to get a better, because there is sort of that baseline that you would need. And if you don't have the HPV, then you're good for 5 years. I really like that, and I think that's a way for doctors and physicians and providers to talk about that with women, because it is cancer is always a very scary thing, as Jenny shared with us. Let's see what I have. So let me get back to my questions, or the
Sabrina, sorry, I don't want to interrupt you. There's a
Yeah.
really good one for Dr. Dar that was just put in the chat.
Oh, okay.
What are some communication techniques that you use for parents who are hesitant?
Great. Yes. That's where I was going, actually.
Yeah, vaccine hesitancy, of course, has been a tremendous topic in an era of COVID. And I've been dealing with vaccine hesitancy for my entire career, though it's not new. It kind of came to the forefront in the last few years, though. And I think that starts really with some very simple, there's some psychological concepts that I think are important. One, we educate all of our staff that they are not to say, oh, do you want vaccines today? Which is a terrible question to ask, because it puts the impetus on the families to say yes if you're going to give those vaccines. Instead, the message is always, if they come to the front desk and ask our unit clerks, which happens all the time, oh, are we going to need vaccines today? They say, oh, You might. That's a discussion you should have with the doctor and the nurses when they room the patients. If they see they're due for a vaccine, say, oh, Dr. Dar's going to come in. He's going to recommend that you get these vaccines today. And so just that, and so we and when I recommend the vaccines, I say, you're due for these vaccines. That's what we're going to do. My presumption is that it's going to be a yes. And it puts the impetus on families, if they want to not get vaccinated, to say, no, I don't want it. And I think that's a very fair way to deal with it. So that's the first thing, is just that consistent messaging that says, this is part of what we do. It's part of what we expect you to do for your children, because it's the right healthcare decision for them. And so if you don't want that, you're going to have to speak up and say no. I alluded already to some of the messaging around HPV vaccination that I use in our patients. But one of the things that I've referred to myself as and my colleagues as is an evangelist for vaccines. I never presume when a family is vaccine hesitant that they're vaccine hesitant because they want their kids to get sick, right? Their goals are precisely the same as my goal, which is that their kids be happy and healthy and disease-free as much as we can possibly do. They may have different ideas about how to get there, but I am continuously talking to those families that are vaccine hesitant. I don't kick them out of my practice. I think that's not the right way to go about it. I don't shame them, but every time they come in, whether it is for a well child exam or a rash or a cold, we talk about vaccines. And as families trust me for years and years to answer other healthcare questions, it's interesting to me that some of the families who I thought would never consent to vaccination because of the way that they came in with their infants and their attitudes about vaccines when they had infants, as they have seen me and my colleagues, and we've done things that have helped their children to grow up happy and healthy, that eventually, for a lot of those families, they say, I trust you with everything else. Maybe I should start trusting you about vaccines. And so
trust is really key, I think. So, and I hate to kind of cut you off. We have a final kind of say, because I did want to hear from all of the panel, and Dr. Dar. Everyone has been just terrific, and kind of bring it back to focus to the vaccine. As Dr. Dar, you had talked about your passion and compassion for the patient and being able to support them in making that decision to vaccinate. I'd like to ask the rest of the panel about strategies that you have or impact of the vaccine. So we'll start with you, Dr. Vroman.
I would just really highlight what's previously been said, and they may not make the decision today to vaccinate, but I'm going to talk about it again the next time they're in. And again, and we've had patients at the pharmacy counter say, well, you recommended my flu shot last time, and I'm going to recommend it. I'm going to recommend it next time too. And it's not to be a pain, but it's because I care about you and I care about your children and I care about the people that you're interacting with.
Mm-hmm.
And I'm going to keep recommending it and, making that strong recommendation. And, like Dr. Dar said, be compassionate about it. Choose words wisely. Don't be, argumentative, but I'm recommending it because it's what I would do for my dad or my daughter. And I often lead with that when I get asked. I vaccinated my father with pneumococcal. I vaccinated my daughter as soon as she became age with HPV. Was she happy with me? Absolutely not. But she'll be protected. So constant messaging.
Thank you. And Consuelo, because you're right there in ground zero in the middle of children and parents.
Yes, just as everyone else has said, just giving firm recommendations and consistent messaging from the time they step into the door, meeting our front desk staff, to when they see me in the back of the clinic. Again, they may not make that decision today, but every time they come in, I'm going to bring it up again because whether you have more questions or you're ready to actually get your child vaccinated that day, I don't want to miss any opportunity to vaccinate.
Yeah, opportunity. And I think that that's, consistency and opportunity, because even though it may feel like I keep bringing it up, it's sort of like, how babies 7 times before they like a food or not, they need to kind of taste it. I feel sometimes that's, is getting used to the idea also. Dr. Wu, so you and I work on this very question is, what does it take for providers to, sort of have an impact on patients and their kids?
Yeah, so most of my my patients are over 45.
Right.
I'm sort of out of the window for recommending, although I really, I still talk about that vaccine. I talk about their friends, their family, their nephews and nieces, their children, of course, and how I certainly would encourage it so that, we can avoid any future cancer experiences in their family. And so that's my sort of contribution to that. And of course, being on webinars like this, so.
Yes. Any last words before we end? And I guess, Megan, you'll take us home. But I really appreciate the panel. And I wish that I could have, been, if we were in person, and not that this was a bad thing, but I think maybe we'll be in person next time. I feel like we could have really engaged in a way where we could have had, and this was a wonderful discussion. So thank you all. I learned a lot. And also, Megan, take us home.
All right. Yes, thank you. And a special thank you to Dr. Harper. We did not ask her to stay on until 2 seconds before. So we appreciate you for staying on and for helping us answer questions in the Q&A. We would not have been able to keep up with that without you. So thank you. So thank you to everyone who attended. At one point, we had 250 people on this call, which is incredible. We wanted to share some resources with you. Please check out the HPV National Roundtable. You will find all sorts of information and resources there. Of course, information with the CDC and with the Michigan Department of Health and Human Services, the American Cancer Society. You can find support for patients in your area, as well as volunteer opportunities. Next slide, Carrie. I think we lost our slides.
No, that's it. That was the last slide.
Okay, so that is it. We just want to thank everybody for attending. Please remember to fill out the survey, because that is how you will get your CME certificate. And just a round of applause and thank you again to our incredible speakers and panelists today. Thank you, everybody.